So we will have some questions at the end after Dr. Lisa Barrett's presentation.
I had a question about the consultations when you talk about the provincial governments having their plans. Are these provinces? Are they provincial governments, or are they and are they part of the federal provincial territorial process, or are they just provincial plans that, like, this is a blueprint that we've got? And then how will the final blueprint be taken when you say to WHO? Is that going to be from the government of Canada, or is that going to be as an NGO who has status at the directing council?
Yeah, I think it may be useful to kind of have that
Okay.
discussion at the end. Yeah, thank you. Thank you. So open for questions for both Jordan and Lisa.
Thank you both for really interesting presentations. So this is a question for the entire panel. So we published the updated BC Care Cascade last year for 2018, and we were measuring our progress towards treatment uptake, that 80% target, based off people that we'd diagnosed. That was the denominator. And in the CanHEP-C blueprint, in the indicators section, that is aligned. It's also aligned with the WHO indicators. I'm a nerd, I checked. And one of the criticisms that we got was that we'd measured our progress towards that target, and this was from Greg Dorr, that we'd measured our progress towards that target among people who were diagnosed, and he thinks that we should be measuring it among everyone who's infected. So we should be aiming for 80% treatment among everyone. And I just wanted to kind of gauge what your thoughts on that are, and also kind of thinking about, like, is that what we're doing in the modelling studies? Like, when we're modelling, you know, how many people do you have to treat per year to reach the target? Is that the target as the indicators are put forward in the blueprints? Or is that this aspirational target of 80% of everyone who's infected?
No, because remember that there are two types of targets. There's the outcome targets and the service coverage targets. And the treatment number, whether that was right or wrong, is actually a service coverage target to meet the outcome target. So the idea is you have to meet 80% treatment of the diagnosed fraction. So you have to diagnose 90%, treat 80% of those 90%. And if you do, the modeling would suggest that that will be one of the components, not the only one, but one of the components to achieve the 90% reduction in incidence, actually 80% reduction in incidence for Hep C, but and 65% reduction in mortality. So, I mean, I think it's a fair point, and I guess I would say about all of the, I'd say two things about that. One is, it was surprising to me that the WHO chose incidence and not prevalence as their target, as their outcome target, mostly because it's much easier to measure prevalence than incidence. So if I was doing this, I might have done that, except that one thing I like about incidence is it focuses on prevention. So it really gets to prevention, which is so key. But the other thing about it is that although these WHO targets are what's set, these are global targets. We match them for the most part in the blueprint, but you will see that a number of our targets are actually above the WHO targets.
Yeah, the needle and syringe distribution, definitely.
And a few other things. And I would say that that's the way I would think about them. These are minimums, because remember, this isn't eradication we're aiming for. This is eliminating it to below the burden where it's a major public health threat. But I think even once we get there, and I mean, I can't stress Lisa's point enough, that the thing about elimination versus eradication is even when you get there, you've got to maintain everything, or you go right back to square one. So it's not like smallpox where we can stop vaccinating people. So we'll have to keep doing this.
So just to be clear, if we keep assessing treatment uptake among people who are diagnosed, we're all going to be doing the same thing in Canada. Is that right?
I mean, yes, except that the key is the diagnosis rate is going to get to that 90%.
Yeah.
Like I'm confident it'll get there.
Well, we estimated that we're sitting there in BC right now. And I wish I had recorded you saying that so I could play it for Greg. Thank you.
I'll call him and tell him.
So just a minor point related to these issues. So these measurement issues are coming up globally, and WHO has called up a meeting to discuss some of these issues, like how we will validate the elimination. And so that will inform some of the discussions that we are having here as well.
We have a couple more minutes, so
So
ask quickly.
heroic effort in PEI. And please invite us all for the elimination party, because I think that'll mark the efforts that have been done and will encourage us all to be like PEI. So I think that was a very inspiring presentation in its content and its delivery. So let me say that. So now. So the numbers went by fast, Jordan, and all of a sudden we go from being, we go from worst to first in a set of slides, and it's unclear to me. Like the 10,000 a year, I think everyone needs to understand that's going to be a tad bit hard, okay? But if that's true, what changed sort of functionally is that, are there less people viremic than we thought? Are there less people undiagnosed than we thought? What's the driver of the change in the analysis? Because those are the only two things I can think of that would have changed the numbers so fast in the face of 50% decrease in treatment starts.
Yeah, so it has nothing to do with the percentage of treatment starts, because it's based,
Fair enough. Yes,
right,
yes.
because that's not a model output.
Yeah,
that's something that you're putting in. You're saying we have to treat this many people to achieve that. So
Fair.
given that the senior author of that paper sitting beside me, I might let him answer the question, but I think it's better data on the prevalence and the viremic numbers. The other big question mark in all of the modeling is the incidence, because it's more or less set at a fixed value. And we don't know, for example, with the opioid epidemic, it's estimated as a function of prevalence, which is like a reasonable way to do it, or at a constant rate, which is another reasonable way to do it. Not the best way to do it. We would really like to measure it. And obviously with the opioid epidemic, it may well be increasing, which then changes all of our predictions. But I don't know if Naveed, if you want to comment.
I think it's also a combination of looking at in fact, like we didn't have any treatment data available for Canada. It was based on guesstimates. So in this one, we have a little bit better quality data on treatment uptake. So that is one thing. And then all of the other things, as things are evolving, more data is becoming available. So it helped us to improve upon that. But the main issue here is to think about, you have these 10,000 people who are being treated at the peak of what we see in terms of treatment uptakes. Whether we will be able to maintain that would be a good question to ask. I think most probably by next year, we will have a sense whether we are able to maintain even 8,000 treatments per year or not. And if it starts to go down, then we will have to see like how we will do that. And as we reach towards more and more treated people, the lost people will be more harder to reach, and that will become much more difficult, because these models are not thinking about how hard it is to reach a certain number of people.
Sure,
And
they
that
just
is
count
one of the
every
key
individual
things.
as the same.
Exactly.
So we overestimated potentially the number of people who are still viremic. Is that kind of what you're saying?
No, what I'm saying is like when we have treated people who are already engaged with the system, and it will require more effort to engage people who are not engaged in the system. And as we go further down in our success, it will become even harder. And then it will require much more effort to reach that same number of people.
So the good news is 10,000. The bad news is 10,000 in 2026 will be much harder than
Yes.
10,000 in 2021.
Exactly.
That's exactly why I showed the numbers, because it looks like the curves are really easy, and you just sort of if you look at the labels, it sounds like, okay, well, if we just do what we're doing, we get there. But 10,000 a year is really hard to do. But I think what you're asking, what changed, is that they actually had numbers on the number of people treated, which we didn't have before. So they knew that, like, they actually could see what that impact was, and then said, if you maintain that, where do you get
So
to?
we're further ahead than we thought.
Exactly.
Okay, got it.
That's why I showed that, but I also wanted to show what was necessary to
So
get there.
we will take one more question and then we'll move on to the oral presentations.
So I'm really excited to see all these steps to control HCV in Canada. However, as immigration is a key element in Canada, so what are the steps to be taken to control the virus at the level of immigration?
Yeah, so I'll jump in. I mean, it's an important point that newcomers to Canada have a high burden of hepatitis C, obviously depending on where they come from. And they are identified as one of the priority populations in the blueprint. And there's a number of suggestions on how to address, because obviously that varies again, as with many things with Hep C, it varies widely across the country. So there are fewer newcomers in PEI. Fewer.
I'll take
Okay.
the comment on that.
Okay, maybe not. Sorry. I think there are fewer than in Ontario, just to guess. but there's clearly points, and there is a whole section discussing what are some of the barriers that newcomers face and what are some of the strategies to overcome them. But there's no question that addressing hepatitis C in foreign-born individuals has to be a priority if you're going to get to elimination.
I'll briefly, I'm going to comment on, and not that there's that many, and I'm a newcomer in PEI, so I don't count. I've already been tested. But the important part of what I presented, and I keep harping on, is that public health owning something at a governmental level is important, because there was a large program 1.5 years ago to bring a lot of people from Syria into PEI. And almost all of those people have been tested because public health has the mandate now and is there to engage people in health through a public health lens for those people, for vaccinations, et cetera, et cetera. Everybody came to us in place when they were getting vaccinations and other healthcare associated things through public health in PEI. And so things like that, I know it's a small place and we have fewer people in PEI, but things like that can be mandated when the public health legislation gets used for good, not evil, right? And if it's not owned within public health, it's an external thing that they're doing. So I think, again, it just speaks, I think the newcomer and new to Canada part of this is actually integral when you think about it from a public health approach. Public health approaches happen best in public health. Just throwing it out there.
Thank you very
Thank
much.
you.
So this is a good segue to the next presentation.